And today on the Falls Community of Practice, I'm very happy to have Jody able to share with us about the great success that her hospital has been having with Falls, and I'm sure everybody else is ready to pick up some pieces, if not all of the pieces, to why their success was great. So Jody, if you want to go ahead and introduce yourself, and then you can start and let me know when you'd like me to forward your slides.
Okay, great. Thanks, Jennifer, and hi, everybody. I appreciate this opportunity to share what we've done here at Mercy, because I think hopefully we can help you guys maybe grow your programs and just look at the total package and see maybe something might be missing, and this might spark an idea or two. When I looked at the theme or topic on policies and procedure, I asked if I could just present our whole program. It's too limiting for me just to present the policy and procedure of our program. So she was gracious enough to let me have the 30 minutes to do that, and then I asked for another 15 on so we can have a little discussion afterwards. So that's so important, is that discussing and networking time. So, okay, so why don't you go on to the next slide here. I always want to see what the presenter looks like, so I put a picture of myself in here so you can see who's talking to you. And about our facility, Mercy Clinton is a smaller acute care facility. We're licensed for about 136 beds. We have an average daily census of 60 patients per day. And I've been a nurse here at Mercy. It's been my only job for the last 21 years. And 16 of those years I spent on the medical surgical unit. We have a 30-bed unit here. So I've definitely had my share of patient falls in that time. I have been a certified wound care nurse for about 13 years, and in the last about 4 years, I guess, I got my ostomy and my foot care certification as well. So that is truly where my passion lies, is with wound and ostomy care. In early 2010, I went to our leadership, actually our CEO and CNO, about establishing a full-time role as a certified wound care nurse, because I was receiving so many consults while I was working on the floor, physicians, nursing, just people coming up to me wanting me to see this patient and that patient, and it wasn't really fair to my coworkers to be leaving the floor, so I do it on breaks, do it on my shifts off, on my days off. And then after several months of discussion, that role became a reality with one caveat. The leadership did not feel that I could support a full-time FTE just by doing wound care. So they added the role of the fall safety coordinator to create a full FTE. So 50% of my job would be doing patient fall safety stuff, and 50% would be seeing wound care patients. I had been involved in a quality improvement project on our med-surg unit in 2010 that was quite successful. We looked at patient falls around toileting, because on our unit, 50% of the falls were just that. They were around toileting. And what we did, we just eliminated the falls for our 6-month trial period by removing the bedside commode from the line of the vision of the patient, as well as implementing a stay within arm's reach intervention for all those patients who were considered to be high fall risk. And we use the Morris risk assessment here at this point. So that's how we deem a patient at high fall risk, or at the nurse's discretion based on their medication, things like that. So I think the success of that and the publicity of that throughout the hospital kind of set me up for adding the fall safety coordinator to this job. So adding the ostomy service in the last 2 years has really affected the amount of time that I can put into the fall safety stuff. So I would say roughly right now about 25% of my full-time job is devoted to patient fall safety coordinator. So you can go on to the next slide. We began this journey back in January of 2011. That's when I started my current position. I had the opportunity to join our newly formed system-wide collaborative with Trinity Health for patient safety. Our goal was to actually reduce our acute care falls by 50% across our whole system for Trinity Health. I was very involved in this collaborative over the next 5 years. I was not only a collaborative member, but was our site lead, and also was asked to be a steering team member about a year after starting this whole process with them. I worked on many of the subgroups for the collaborative, and I guess it was what better way to know the process and policy inside out than to dive with both feet in first and have our local representation there at the system level. So it was nice being in the front seat for the whole thing. I wouldn't have been able to do this unless I had the dedicated time in my current position. So that is so important, is to have support from your leadership, giving a coordinator responsibility for the whole program and giving you the time to work on this. So today I'd like to share with you several different aspects of our program that I feel have contributed to the success that we've had today. But first I'll show you the graph of our falls for 1,000 patient days over the next 5-year time span. There's our graph she's just put up there. Like I say, I think the huge success was having one person dedicated to be responsible for this. So let's see. The graph is entitled Adult Inpatient Falls, so note that this does not include ED. They're kind of a separate entity. We've focused on behavioral med, PCU, med-surg, OB postpartum, and CCU falls. So December 2010, we began with an average of 3.4 falls per 1,000 patient days. I started that following January, getting my feet wet with the idea of fall safety, but was successful in reducing falls pretty significantly just by the stay within arm's reach intervention that we had worked on the med-surg unit, and we implemented that across the hospital. So that fall from 2010 to 2011, I feel was attributed just to those interventions that we researched on our med-surg unit. We found through our collaborative that there was very little published research specific to fall safety in acute care patients. So we did a lot of sharing across our system with successes and failures and what worked and what didn't, I guess. So in 2011, we continued to work on fall-specific interventions for the adult inpatients as well as those high fall risk interventions. And again, that was based off that Morris Fall score. We used that across our system in the majority of facilities, which is a 45 or greater score. On that assessment, we looked at high-risk fall medications. Locally, we used the Beers list from our pharmacy. And at the nurse's discretion, if something, Morris Fall sure is not all-inclusive, there may be something else that the nurse may deem them at a high fall risk. So it wasn't until 2012, I guess, when the meat of the education, called our intervention period here with a little red arrow above 2012, was given to our staff. And basically it was just what we do, probably a 1 to 2 hour lecture that was mandatory for everyone to give them that education, let them know what we've decided to implement our fall program. So to really kind of put the heat on people and make them start being accountable for things. So in 2013, our system merged with CHE and our executive sponsor changed. So CHE had been working with falls expert from the VA, Dr. Patricia Quigley. Some of you may be familiar with her. So based on her findings, we tweaked some of our interventions a bit and broadened our scope to include injury reduction interventions. And I'd like you to write this down. If you do a Google search, she has a toolkit that can really help you guys a lot. I used it quite a bit. If you just Google VA Falls Toolkit, that will give you quite a few of her tips that she gave us. So maybe something you want to look into. And I am so very proud of the hard work and dedication to patient safety that our staff has done to reduce our falls. So far this year, for March 15th, we've had 4 falls. So hopefully our number will even come down more in 2016. We're certainly not resistant to falls, though. One of our falls was a fracture. It was a person who was left alone in a shower who shouldn't have been left alone. So we're certainly not perfect by any means, but we've definitely improved over time. So, okay, so let's move on to our fall safety interventions. Which, darn it, my thing. I'm hoping you're caught up with me. My computer just timed out. So we should be on the fall safety intervention slide, and you should see
here we are.
Oh, all right, perfect. Should see standard interventions. We broke our interventions into two categories. Standard, meaning all interventions, these should be done for any adult inpatient. And then just to review the list, hourly rounding, I'm sure everybody has heard that term. We look at pain, personal needs, and positioning here. Of course, we want to maximize mobility to keep people up and moving, appropriate lighting, room free of clutter and trip hazards, non-skid socks and footwear. Supervised transfer is needed. Make sure the call light and their personal items are within reach. Standardized patient and family education. And I should mention, too, hopefully you all got the email that Jennifer sent out a couple hours ago. It's got about 10 different attachments, including this PowerPoint. But all of the stuff that we use, that I've created, that I've gotten assistance with from different folks in our facility, it's all yours. You guys can do what you want with it. You can make your own stuff. You can tweak. You have liberty to use it as it will help your program. We want to also make sure that bed is in locked and low position and make sure their hearing aids and glasses are on, are close by if needed. So that is what we do for all adult patients, our standard intervention. Now moving on to the targeted interventions on the next slide, those, again, are deemed by the nursing assessment if they're deemed at high fall risk. And I have these in yellow print because yellow is the national color for fall safety. I have a feeling most people are aware of that if you're dealing with falls in your facility. So a list of our targeted interventions would be safety tools and technology. That would include use of a gait belt. Certainly gait belts are not going to prevent falls, but hopefully give you more leverage as you're assisting your patient to the floor. You're not pulling on their shoulders, and it's just for their protection and injury reduction. Alarms, bed alarms, chair alarms, your lift and transfer devices, recliners. We use seat positioners. I'm hoping I can say names of products on here. If not, let me know. But we found a great...
Nope, I think that's fine.
Is that okay? All right.
Yeah,
we use
the
Sage Prevalon seat positioner. We had several people scooting and sliding out from chairs, and that product has stopped that incident for us. So that's a wonderful device. They're quite pricey, but it's worth it because it's eliminating a fall and potential risk. So kind of keep that one in mind if you have that issue going on in your facility. Also low beds, we have fall mats as well that we use at times on those folks at risk for injury with fall. The next intervention would be pharmacy, physician, nurse case-by-case analysis. We do daily interdisciplinary rounds. We have meetings going room to room and making sure everybody is in tune to what's going on with those people. We want to treat conditions and comorbidities that puts a patient at high fall risk. PT-OT consults, of course, we want to get them involved for strengthening and gait training, pain management, different interventions that we can do to keep their pain under control. We want to cohort them near a nursing station if they have cognitive impairment or a risk of elopement, things like that. Use of sitters, use of video monitoring. We just started using Avassist, the video monitoring thing a couple months ago. Behavioral management for those cognitively impaired people, repeat, reassure, redirect, and regroup is always helpful. And then orthostatic blood pressures upon admission to check for issues with syncope and low blood pressure, followed by checks PRN. Okay, we'll move on to the next slide. This is just a bunch of little pictures I compiled for you. It shows our high-risk interventions. Our chair and bed alarms, our yellow double-sided slippers, socks you can see there, the yellow laminated fall risk signs. We use 3 of those, and again, you've got a copy of all those in your email. We locate one outside the door, the one right in the center. We have a magnet that holds that up. The yellow side is up. If you when they're a high fall risk. Otherwise, we always leave it in place on the opposite side. And the opposite side is a gray sign with our hospital logo, and there's a little question at the bottom. Is your patient at fall risk or fall risk? I can't remember, with a question mark. So it's a prompting cue for staff to be aware of that and flip it if it's necessary. The other sign gets located above the toilet. You can see in the center picture right below that other one, that's a stay with me sign, bright yellow again. All of our fall stuff is in bright yellow. And then we also have a sign right above the head of the bed that you'll see shortly. Again, that's just for awareness. Whoever walks in the room, we use plain language here, not the symbols that people are guessing what they might be, plain black and yellow language here. So we have a fall safety brochure picture. That's a trifold that we created here at Mercy, and parts of it are used throughout our system now. So nursing staff is responsible to pull that brochure and discuss briefly with the patient and the family within 24 hours of admission about the fall risk potential for being in the hospital and what their responsibility is as well. So let's see, and I had the opportunity to help with the creation of our whiteboards that we put up a few years back. You can see the big yellow call, don't fall, that I have circled there. And there's also a spot right next to it with the fall score. So everybody has been educated on what that stuff means and what their role is. And you can see in the middle picture at the bottom, there are a couple signs posted in addition. Well, there's another sign. In addition to our yellow sign above the toilet, we have a sign on the side wall that says safety tops privacy. And this is just to explain a little bit more about why somebody is staying in with you toileting, just as a reference. Helps with family too, because it's not normal to stay in with somebody. It was very uncomfortable and quite a process to get staff in the mindset of that. But really, falling back on that 6-month research project that we did, it really helped because they could actually see, wow, you know, we made quite an improvement there. So, if you go on to the next slide, please. This is a picture from our simulation lab with Manny. We named our sim man Manny. He's all decked out in his high fall risk safety interventions. Note his ID band there on his arm. It's got a yellow fall safety sticker that says high fall risk on there. He's got his yellow socks sitting at the bedside, and he also has the educational brochure sitting right there. Also, you can see the yellow card above the head of the bed that indicates the high fall risk. Again, on the opposite side, it's gray, just with that little question and our hospital logo on there, just to prompt the nurse or the aide to turn that over if they are at high fall risk. We also have a couple other cards. One is a neon pink card that has the fall risk score on it. So if they're a fall risk with their Braden score of less than 12, that gets turned over. And there's another lime green card up there as well. If they have an open wound on their body, then that gets turned over. So it just helps with staff communication across the system. Like I said, we use plain language here. Everybody should be able to see what's going on instantly on the surface anyway with that patient when they walk in. Let's see. I told you about the door signs already. Okay, so let's move on here to the next one. The educational process is ongoing. This truly never ends. The second you let up your guard, something happens. I just did that last month. I didn't get to my audits. I usually do room checks and make sure the interventions are in place and then get that back to the directors so they can see how their staff is doing. But I have not had time to do it the last couple of months. And like I said, we just had a fracture in the shower. So I blame myself for that as well. Take that responsibility because I let up and you just can't let up. So I teach this stuff at night, it seems like. We've done it so much. So initially, once we established what our fall safety interventions were going to be, we had to get the information out to staff in a formal kickoff program. And that's when I mentioned that mandatory 1 to 2 hour classroom lecture session that we rolled out the expectations of the program. This was mandatory for nursing and ancillary staff, so everybody in the building knew what was going to happen. Let's see, we also used HealthStream. Trinity had made a very nice, extensive HealthStream assignment that was assigned to everyone as well. That was about 45 minutes to complete, just a little bit different learning style though, and it could be done at their own pace as well. So we also put out different items of the program that we can improve on. We sometimes we'll do little impromptu things in huddles. Sometimes we'll do things in unit meetings just to keep them attuned to everything. If there's a little deficit, if they start falling back on placing their signs, we'll bring it to them in their huddle and remind them about that, bringing the signs out, reminding. It's always on the forefront of everyone's mind. So let's see, what else here? In 2013, we pushed the same education all onto ancillary staff again, and I just repeated that. I'm doing 18 sessions with ancillary staff that their directors are making it mandatory for them to come on actually just a small portion of the program as far as setting the alarms, the bed alarms, the chair alarms, things like that. They need to know how to function it. Our particular beds, we have Hill-Rom Advanta 2s throughout our hospital, and they have a green indicator light when, in my terms, it's safe to leave the room. Once the alarm's on, the 2 side rails are up, the bed is in locked and low position, that green light is on if they try to set the alarm. So it would be a yellow flashing light if something was not safe and they were trying to set the alarm. So we review all of that and the expectations of when you're walking through the hallway, you are peering into those rooms. You're not just looking down or looking at your papers. You're actively looking in patients' rooms to make sure things are safe. You see that green light, you don't see the yellow light, or you don't see a patient trying to get out of bed. If you see that patient trying to get out of bed, you stop them, you stay with them until the nurse or the aide arrives. I have to say, one of our most unique and fun ways of learning was by using Falling Francie. She's on the next slide. Falling Francie, this was, I think, the most enjoyed activity that we did among everyone, and we've done it. We just did it again in January, so it has been a couple years since we rolled it out. But this is an independent learning station that you guys might want to try at your own place, because we just had such roaring evaluations. It was pretty fun to read them and to listen to the staff in the room doing the project. We used a sim lab, and we dressed Manny up as our fall mascot, which Francie, there's a little picture, a cartoon picture of her. Her name is Francie. We established her when I first got this role. I thought, just kind of have fun with it. So a blank worksheet was left in the room with a short scenario at the top of the page with about 20 blanks, 20 lines to fill in that things were wrong. We set the room up so they could identify some of the risks that would be like trip hazards and things like that. In this photo here is myself and Margaret Alstead. She's one of our dietitians who's on our fall team. So I wanted to snap a picture of her, of us in the sim lab during that, because I knew I was going to be talking to you guys, so I wanted to share that. So the sim lab was a total wreck. We had so many fall and trip hazards in the place. And against our fall policy, we had gray slipper socks instead of the yellow slipper socks. The educational brochure was folded in an airplane fashion right down by the garbage can. We had extension tubing dangling on the floor with the oxygen and the IV. There was lots of poles, IV poles, cords to trip over. We had water spilled on the floor. Lack of hearing aid glasses. They were away from the patient. She couldn't reach that stuff. We had linens on the bathroom floor, bed linens hanging on the floor. The bed commode was placed right at the bedside. We even had an INO sheet that indicated very poor intake, which could lead to weakness and a fall. So we had about 26 specific issues, and we asked them to list about 20. So my office is right next to the sim lab. So the answer sheet was then stuck in my door, I guess they compared their answer sheet to the list of the 26. And Ambien was included in a little scenario that we gave as they walked into the patient room. So I also had a like a high-risk medication list, side effect type of thing on Ambien because it's such a dangerous sleep aid. So that shocked a lot of people when they were reading through that. The lab was left open 24/7 for a week. People loved that flexibility. They could come in as they want. Ancillary staff, again, were invited to attend. This was not mandatory. It was just come. But we had probably 3/4 of our staff attended. So I think the word spread after a few of them had fun with it. So it was about 10 or 15 minutes. It was very quick and easy. Some did them as groups, some did them alone, but we got great feedback. So let's see. I think that's about it on that one. You want to go to the next slide? And like I say, we'll save room for comments and questions at the end. We'll go on to staff accountability. Here at Mercy, we use a just culture process, very non-punitive way of looking at an incident. I'm a big person, though, for everyone being accountable for their own actions. And I believe after coaching several times, there needs to be some consequences if the same issue continues to arise. A couple years ago, we had the Nursing Executive Center, the advisory board company come in, and they just gave a very nice program to our nursing staff along with talking about never events. And a part of the program was about the nurses being accountable for their own actions. By a raise of hands, the speaker asked how they would like to be informed of an issue or a never event. And many hands in the room were raised about learning from case studies, and they wanted to know if they were involved by putting their names or initials on things so they could pay closer attention. I was very hesitant about that because I piped up and I clarified that truly this is what you guys want, because I remember being in school, I hated to have my name on the chalkboard, so I didn't like to be called out. But boy, oh boy, the majority of people really wanted that. So with the next patient fall, and because I'm the wound care nurse too, I also do it for hospital-acquired pressure ulcers. I created some case studies on posters, and this took a lot of time, but it was very effective. I wasn't the most popular person, but it truly opened up the lines of communication with staff. Not 30 minutes after I put the poster in the locker room, I had a couple nurses marching down here. Why are my initials on that poster? Well, it truly wasn't that person. It was another person with the same initials. So there was a lot of discussion about that. Like I say, it wasn't the most popular, but I reminded them that the majority voted for this. So this is just a slide of one of those case studies that I had posted. And I try to bring out the positive, too. You can see a couple little thumbs up from the smiley face there. I don't want to just be all the negatives. So you try to bring out the positive, too. And documentation was also included. There were gaps in fall safety documentation with the circle around. You can see right under case number 2. So trying to use it as an educational point as much as possible. And then on the next slide, there's also another accountability poster, and I planted this one right in the conference room, the locker room, for several weeks. Missing documentation was also put in on this one too. So it definitely gets their attention. Nobody likes these posters, but I think they all learn from them. So if we move on to the next slide, you can see our post-fall huddle form. This is part of our post-fall process, and it's in yellow, of course. It's a QI tool that we use. It's not a part of the permanent record at all, but we ask the staff involved in that fall to fill it out right when the fall occurs, and it's meant to be like a super quick crime scene investigation. What can we do to prevent this from happening, and why did the body go down? That's all we want on this sheet. And the rest of your incident would go on to a incident voice report is what we use here. And then you also have the actual EMR documentation. We have a form in there that we document. But those responsible for the patient, as well as the supervisor, unit director, and physician, the fall unit champion, we had fall unit champions on each unit. They would all come together because a post-fall huddle would be called after a patient falls down. So those people can help get the patient off the floor safely as well by using a lift. So we put lots of heads together to see actually what happened and how we can prevent it immediately so it doesn't happen again. This is a form that we also included a small checklist at the bottom to make sure all of our process gets implemented. People were missing this, they were missing that. So this is a nice tool. If a fall happens, this is what they pull, and it'll walk them right through what needs to be documented. It has worked so much better for us by adding that nice little thing at the bottom. Is this done? Is this done? We also include our pharmacy. This form gets faxed down to our pharmacy, and they are tasked with reviewing the medications of the patient within the 24 hours of that fall, and then making recommendations to the physician to lower the dose or give an alternative medication if that one truly is a high fall risk medication for the patient. And again, this is not an incident report. It's just the down and dirty, brief 3-minute investigation on how the body went down and how do we prevent it from reoccurring. We use it on the units for QI purposes, then it stays on the unit. Okay, on the next slide. Oh, I'm going over my time. It's almost 10 after. I'm sorry. Let's see. There's a great deal of investigation, reporting, sharing of all the falls events locally and a lot of times across the systems, different ideas on how we can prevent future falls. So these are just some of the tools that we use, some of the places that we report our falls. It shows the communication across of our system. The next slide shows awards and celebrations. This, I think, is so very important to celebrate and point out the good things along the journey, trying to get your falls reduced. There's many ways to do this. If there's a big issue with falls in the units that you're on, I would encourage you to start with small goals. Start with a 1 or 2 month award, maybe acknowledge, celebrate in 2 months, you know, if they're fall free within 2 months. And celebrate it hard, really make a big deal about this stuff because it is a big deal. If they've had 5 or 6, 7 falls a month and all of a sudden there's only one, that's huge. Really give them kudos. As things improve, maybe move those awards out to quarterly. I've got a few pictures here of our celebrations. The poster that you see, the framed poster, is our Traveling Safety Award. We do this every 6 months and present it at the Shared Governance Council in, let's see, it would be August and January for the unit that has the lowest falls per 1,000 patient days. It's a traveling award, so it travels around. Whoever has received it that month will get that along with the nice little goodie basket. And then what's kind of cool is our local DME, they sell uniforms and shoes as well. Well, the director has agreed to donate a certificate for 1 free pair of non-skid shoes, up to $100. I was pretty impressed with that. She said we can use that for our drawing, and the unit that wins that safety award, everyone's name goes into the bucket, and one is drawn out to win that pair of shoes. So it's always a fun time. People look forward to that every 6 months. So, I've got another picture of a basket that we just delivered. 3 of our top units just delivered those beginning of March. That was a goodie and fruit basket. We also delivered cookies at one point, the Yellow Star cookies. We delivered those. Just a nice congratulations note with that, a pat on the back, and it really helps if you can get your leadership involved. On that basket at the top, I had all of our senior leadership sign it, our CEO, all of our administration people. So it just, the more they support us, the more staff feel it, and I think the harder they try. Everybody is believing that this program really works now, and we're definitely changing our culture. So, like I say, don't shy away from the celebrations. That's a huge part of any safety program. Everyone loves to get kudos. If you switch to the next slide, this has been a long journey for us. It's taken over 5 years. It sure didn't happen overnight. It takes time, persistence, teamwork, and a great deal of support, just like I said, from leadership to start seeing that culture change on our units. not carrying out our current policy on fall safety is not an option. Unless a patient refuses, then of course, you know, we document that refusal in their chart. We start, let's see, safety education during the onboarding process of newly hired nursing and ancillary staff. Patient fall safety is an expectation of everyone's job here, and it takes a full team to keep our patients safe. It's not just something that falls on the nursing staff, it's everyone as they're walking through the hallways. Like I mentioned, they're looking in those rooms for those green lights to make sure people are safe. Safety is instilled from the time they step foot in our facility. It's discussed by leadership, CEO, CNO, directors, supervisors, myself, and preceptors. We all at some point touch on that. This is just our Mercy way. It's our culture now. And there are times we don't see everybody's commitment with that. We try to coach. We do what we can several times. But if that risky behavior continues, they just might not be a good Mercy fit for us. So it's really pushed hard that we impress upon patient safety here. Getting your culture to change is a long road that you'll have some ups and downs, more downs probably, but when you look at your fall stats, make sure you're looking at the trend over the year rather than day or month. That can really help because we certainly up and down for a few months, but when we look over the full year, each year, it really made a difference. Your numbers will fall with adequate support from your leadership, and establishing a fall safety program coordinator with dedicated time to carry out the needed education, those audits, the monitoring, just the persistence, staying in everyone's face and keeping it fresh on everyone's mind is definitely needed in a good, strong program. So that's my story, and I hope you could take a little of something from this and improve your program. The last slide has my contact information. You can sure get a hold of me by phone or email. I'll be willing to talk with you offline anytime along your journey. I will be leaving on vacation, though, very soon. On Friday, I'm leaving for a week, so you won't hear from me then. But otherwise, I'll respond with you in a day or so. So I guess we'll open it up now to questions.
Jody. Before we open it up to everybody, I just really would like to thank you, Jody, for taking the time to put this together and then also the time to share with everybody. I know that you, as many people, are in charge of a lot of things at the hospital, and I know this took some time. And I think your willingness to share all of your documents, this is going to help so many people and so many patients across Iowa. I'm really excited to hear the comments, but some of the things that I heard great education, I heard having a lot of fun, I heard accountability, and then I heard celebrations. And when you look at that, I think it probably has great staff satisfaction in your hospital being able to be part of this. So I'm going to go ahead and open up the lines.
Okay.
And so everybody, just so you know, we can hear you typing, and anything you're doing in your office now, everybody is unmuted. So if you'd like to mute your phone, you can if you don't want to talk. But does anybody have any questions, or anybody would like some clarification? And then also, if anybody would like to just let Jody know the great things that you learned today, that would be great.
Jody, this is Denise from Mercy in Mesa City. Hello there.
Hi, Denise. Denise has been on our fall collaborative too. How are you?
I have. Well, good, except I feel like you've been very much more successful in what you're doing than what I've accomplished here. A question, it goes up and down, like you say.
Yes, exactly.
Question that we've had here is we've had our expectations for fall prevention, and we've taken a little bit different approach, although I do like the stay with me thing. We've not been real successful with that up to this point, but we've used a pretty structured approach around use of our bed alarms because a lot of our falls occur with toileting, and most of them actually have been during the night. So trying to look through those patients that are high risk based on our own statistics as far as when our falls occur. I'm hearing from the staff a lot, well, the patient's refusing. So then even though the patient might be considered high risk, if the patient says, no, I don't want the alarm, they're saying, okay. So how are you having that conversation with your staff there?
We went through the same thing, Denise, and still to the day, it still is the same kind of fight sometimes to get people to stay in the bathroom with the patient. It's totally their right to refuse, but I told them before you write patient refused in the chart, you need to give them a rationale and try to convince them, why are we doing this? You know, you're dehydrated, you've got IV tubing, we're giving you maybe some Benadryl, IV Benadryl, or something that can alter your stability. When you stand up, you can get dizzy. You may be on pain medication. It's going through each of those risk factors, why you deem them a high fall risk. So the aides have a tough time doing that just because the lack of critical thinking in a lot of cases. But they need to call the nurse in and have them have that talk with the patient. And I make myself available too if it's a really tough patient. Oops, I'm hearing somebody. Can you guys mute yourself? I'm sorry. If it's a really tough patient, I'll go in and I'll talk to them myself as well.
I'm comfortable with where we're at.
But if they continue to refuse, we just let them refuse and we document that. It's their right. If they want to fall, they can fall, I guess. But we do what we can as far as education.
All right. Thank you, Jody.
Yeah, you bet.
Okay, any other comments or questions?
Yes, I was wondering if you had any examples of what you do for accountability or consequences.
As far as accountability, the directors take that over. Like I say, we use that Just Culture algorithm, and we do a lot of coaching. Sometimes they'll send them back to me for one-on-one education. That was the incident with the patient left in the shower who fell and broke the hip. I met with that aide one-on-one and reviewed everything as far as the policy goes and what their responsibility was. So I helped with that part. It's supposed to be very non-punitive, so they're not supposed to put anything in their record about that. But if this continues to happen, then I would say they would have a formal write-up that will go into their file and things like that. So there's a process out there that the directors follow. And I think then 3 write-ups and you're dismissed. Did that answer your question?
Yes, thank you.
Okay, you bet. Anybody else?
Jody, this is Carrie Stewart in Cedar Rapids at St. Luke's Hospital.
Yeah.
And I heard you mention that you guys have implemented the telesitters. Can you
did.
talk about the success problems that you had with yours? We've had a pretty good program. Just trying to hear about your program as well.
Okay. Well, we got those not necessarily specifically for falls, but to reduce our one-on-one costs, one-on-one supervision costs. We have had to use a lot of nurses, and that's quite a bit of dollars sitting in with the patient one-on-one. So that was our overall goal. And like I said, we just started it a couple months ago, and I think we've been pretty successful. I see them on a lot of my patients with cognitive impairment, wounds, I see a lot of those in there. So it saves, if they're trying to get up, it saves from pulling their NGs out or their IVs, things like that. So we've had good success with that so far. Right now we only have 6 monitors and 1 CNA that sits in the monitoring room with them. But I think most of the time they're all in use, so it's catching on.
Okay, we're hearing a lot of background noise, so if you could mute your phone and if you don't have a question, that would be wonderful. Do we have some more questions?
I shall return. This is Deb from Covenant in Waterloo, and I'm curious about the
sitters, the monitors. So you have a patient care assistant that sits and watches those. Then is she able to speak?
Yes.
This is the first time hearing about that. So.
Yeah, in our particular system, we chose the Avassist system, and it's a two-way communication. We chose a portable monitor so we can move them around room to room, and they hook up through the internet system. But there is also a speaking ability too. The tech can press a button, and she'll introduce herself. I'm Jody. I'm your telesitter. I'll be with you until 11 p.m. Please let me know if you need anything, something like that, just to introduce them if they are cognitively aware of what's going on. There's a privacy thing. There's a button on there that you can press, and it'll go to privacy if they're giving a bath or doing some cares or a procedure, so the tech can't see. But that times out then after a little while. It's a pretty cool system,
And what did you say the name of that was?
Avassist, let's see, I got to write it down, A-V-Y, oh gosh, I don't know how to spell that, Jan, you know? Avassist, A-V-A-S-Y-S-T maybe? A-V-A-S-Y-S-T. Anybody else have those?
Looking up the spelling in my emails. It's A-V-A capital S-Y-S.
Oh, S-Y-S, okay.
Yeah, we have it in Mesa City as well.
Okay, all right.
Yeah.
Great,
We've
thank you.
had pretty good luck, and I believe we have reduced our cost for one-on-one sitters.
Yeah, that's huge.
It is, yeah. It'll be fun to look at it in a year just to really get the dollars to it.
Sure, thank you.
This is Carrie again, Cedar Rapids. We have ours up for the one-to-one purposes too. We've had it since last October, so about going on 6 months or so, and we've had 2 falls since we've had it implemented, but those falls occurred when somebody was at the bedside with the patient, like they had slipped and fell. So we had some pretty good successes, obviously reducing costs, but obviously reducing the overall fall rate as well. We had a hard time at first. We have 12 at our hospital with one person watching all 12. We had a hard time at first with buy-in of, oh, this won't work, that kind of thing. So we only had probably 5 to 6 used for the first couple of months. And then as word kept spreading, we probably have about 10 to 11, if not 12 used every day now.
Oh, that's great. It caught on.
Yeah, it did. It took time, but it did.
Yeah, definitely. Anyone else? Other questions, comments?
Okay, we're going to go ahead and close today. Thank you again, Jody, for sharing. I think it was wonderful information. And no matter where you are with your hospital, with your Falls program, I'm sure that you took something from this and can use it. And I also want to let you know that if you have great things to share, please let me know. I am looking for the next few months to find, I think I have 2 months left for presenters. And then also another great place to ask questions and to share your successes is on HenHub. So if you're not currently on HenHub, please email me and let me know, and I will send you the link. There's a Falls topic area that we can post under, and we can have many conversations. And if you're not part of that, please try to be part of that, because I think that this is a great place for transparency and for hospital sharing. So once again, Jody, thank you so much, and I hope everybody has a great end to their day.
All right, thank you.